Well, we've had diarrhea, so we must talk about constipation also. And with constipation, we really are going to talk about functional constipation. Functional constipation is a delay or difficulty in stooling for at least 2 weeks. Also, it's characterized by hard, difficult bowel movements. Functional constipation is many times a voluntary thing. It's just withholding to avoid pain. So the patient may have gotten over diarrhea or may have pain on bowel movements, and so they start to hold it in, and they get really just basically plugged up, and they can have massive amounts of stool in the intestines. You can actually sometimes palpate in the abdomen. You can palpate the stool in the intestines, and sometimes they will have bloody bowel movements. Probably the most important thing you can do in your evaluation of constipation is a rectal exam. If you do a rectal exam in this child, you feel a rectal vault that's filled with really hard stool, it's most likely functional constipation. Part of your differential diagnosis is Hirschsprung's. Hirschsprung's aren't always diagnosed in the newborn period. Sometimes they have what's known as an ultra-short segment, and so they can have problems with bowel movements, and they may need repetitive stimulation for years until somebody finally figures out that this is Hirschsprung's. With Hirschsprung's, since the defect is slightly higher up, you do a rectal exam, and the rectal vault will be pretty empty. The therapy of functional constipation includes education and bowel retraining. You need to basically empty out the constipated patient, and then proper nutrition, have them sit on the stool for some time, just have them sit on the toilet at regular intervals. Maybe stool softeners are necessary. Hirschsprung disease, we've alluded to on earlier occasions. This is absence of the ganglion cells. Usually it begins internal anal sphincter, which is why when you do a rectal exam, you may not palpate stool. And it's the most common bowel obstruction in the neonate. Usually it presents at birth. Remember, most neonates will stool by 24 to 48 hours. If they haven't stooled, think of anal, imperforate anus, think of Hirschsprung's, think of meconium ileus, okay, or a meconium plug. Those are the things you should be thinking of. These babies will, if they're not picked up early, will have chronic constipation or problems with constipation. But typically you pick them up in the newborn period. The gold standard is going to be biopsy, and you'll show absence of ganglion cells. Enterocolitis is a common complication because they get impacted with stool, and that causes problems in the gut, and it can lead to bacterial overgrowth. So again, the best test will be usually you can do a rectal suction biopsy. If the results aren't really clear, then you just do a regular biopsy. And the treatment for Hirschsprung's disease is basically surgery. You find out the area that doesn't have cells, remove that area, and do an anastomosis later. There are some patients that rarely will have what's known as total colonic aganglionosis, and then you have to basically at some point remove the entire colon. And this is a barium enema. So in the neonate, you're going to get an abdominal film, then a barium enema, then the biopsy. And this shows the transition zone. The area from the arrow on up is the normal area. This area right here, where the arrow is indicating, is the area of aganglionosis. This is a brief table that shows some of the differences between functional constipation and Hirschsprung. Look at the age. Usually functional constipation is after 2 years of age. Enterocolitis is not really seen with functional constipation. Patients with functional constipation thrive normally as long as they're eating okay. And again, we put it in bold for a reason. The rectal exam is of utmost importance, and of course then you can diagnose your Hirschsprung's with a biopsy.